Good morning, everyone. Welcome to an online event brought to you by Parkinson's Community Los Angeles. Today, we're talking about deep brain stimulation for Parkinson's disease. This is a special event brought to you by our program sponsor, Boston Scientific. I'm Judy Yaris, and on the board of PCLA. For those of you who don't know us, we're a Los Angeles-based organization, nonprofit, serving the greater Los Angeles area. And one of the things that we do is bring you this free educational program. Before we dive in, there are a few things I would like to review with you, some rules. We are recording today's event for potential posting on our YouTube channel. If you would like to not be seen by the camera, please take your video off. Also, please stay muted. We're going to have time for questions at the end. You can put your questions into the chat, but if you have difficulty typing, we will ask that you will please wait until the very end, and then we will give you time to do it verbally. Thank you. And then also, please keep your questions on topic. We will try to answer other questions if there's extra time at the end. So today we have our presenter, Dr. Zanos Mason. Dr. Mason is currently a clinical fellow in movement disorders at the University of California, Los Angeles, UCLA. In July of 2021, he will be joining the faculty at the University of Southern California as an assistant professor in the departments of neurological surgery and neurology, spearheading the growth and development of the deep brain stimulation program. He completed his medical degree at Harvard Medical School and neurology residency at Brigham and Women's Hospital and Massachusetts General Hospital. His interests include deep brain stimulation, movement disorders, and the neurophilosophy of free will as it relates to functional neurological disorder. Thank you, Dr. Mason, for joining us today. We're excited to hear from you.
Well, thank you very much for the introduction, and it's a pleasure to be here, and I'm excited to speak to you. It's really such an exciting topic for me, and a wonderful opportunity to share with the community. So I really appreciate PCLA for inviting me, and Boston for inviting me as well, Boston Scientific. Before I get started, I just want to offer a few words on disclosures, because many of my slides, or some of my slides, are adapted from material from Boston Scientific and from Abbott Labs. Both of those are device manufacturers for deep brain stimulation, but I think it's important for me to tell you that I don't have any financial disclosures. I don't have any investments in these companies, and I'm not being reimbursed or paid in any way for this presentation. So if you have questions about any of that, please do ask me at the end. I think it's important to maintain good transparency throughout this, and we'll talk about some of the differences between those manufacturers as part of the presentation. So let's get started. I'm also very happy to make this interactive. So, if there's questions, we can cover them all at the end, but if there's something that you would desperately like some clarification on, I can try to do that during the presentation as well. I'd like to just review some of the symptoms of Parkinson's disease and the treatment options. A lot of this you already know, so I'll spend the bulk of my time talking today about deep brain stimulation, introducing you to what it is, how it works, where it came from, the history of this interest therapy, and then cover some of the benefits and risks of deep brain stimulation. A few minutes on whether you might be a candidate for deep brain stimulation, or who is the ideal candidate, quote unquote, to undergo surgery. Somebody that would benefit from the surgery, for whom the risks of surgery outweigh, the benefits of surgery outweigh the risks. And then go through some of the practicalities, the DBS journey, so to speak, how you might evaluate your options, and then the process of actually being evaluated for surgery and undergoing deep brain stimulation implantation, and then programming of the device, which is when patients see benefit. So starting with Parkinson's disease symptoms and treatment options. You know that there's both movement or motor symptoms of Parkinson's disease, those symptoms that are related to your ability to move and the movement of your limbs, your trunk, your gait. Those include rigidity, speech issues, tremor, slowing of movements, or the medical term for that is bradykinesia, shuffling steps, freezing of gait, and very importantly, balance changes or postural instability. But there are also many non-motor symptoms of Parkinson's disease. Some of these happen before the disease starts, like a decrease in your sense of smell, changes in mood, like depression, constipation. And then others tend to happen as the disease progresses, changes in sleep, changes in bowel and bladder function, as only a few examples. The treatment options are myriad and varied, but the most important medication options are all focused around dopamine, which is lost in Parkinson's disease, is responsible for the difficulty in movement and many of even the non-movement related symptoms of Parkinson's.
Sound. Hi, sweetie.
And
How you doing?
so the most important way that we treat that is by repleting the dopamine that's lost. In the 1960s, we came up with levodopa, which is still the mainstay of treatment for Parkinson's disease, offered in a combination tablet, carbidopa, levodopa. You might know it as Sinemet. This is a medicine that you have to take multiple times a day because it tends to be short acting, but it's very effective at relieving the movement related symptoms of Parkinson's disease. And then in the 90s, there was the development of some enhancers, which decrease the breakdown of levodopa, and then long-acting formulations, the controlled release or extended release formulation. And now in the 2000s and 2010s, we've had the development of more enhancers that extend the duration of action or the length of time that the levodopa is effective, and other medicines called dopamine agonists, which work differently than levodopa, though still on that important dopamine system to allow you to move a little bit better. And more recently, even more new medications, formulations of Sinemet or levodopa, and also other medication classes, most of which are designed to increase the amount of time per day that somebody with Parkinson's disease will feel well, and in that on state where they're moving well, and decrease the amount of time they feel off, while still not having to take medications, very, very frequently throughout the day. Another important concept, just to reiterate, you may have heard it before, is that as Parkinson's disease progresses over years, there is a change in the way that the brain responds to medications. And I'm in particular talking about levodopa. So there's a perception that levodopa causes side effects of dyskinesia and motor fluctuations or wearing off. And while it's true that if patients aren't on levodopa, they may not have these side effects, it really is a process of the disease. So you can see here, this blue area represents the amount of time that somebody with Parkinson's disease feels well after a single dose of levodopa. And the red line is the concentration of the medication in the blood over time. So it rises, it gets to the brain, and then the brain is able to buffer it, to control that concentration of medications so that it doesn't get too high into that pink area above, where you may see dyskinesias or uncontrolled dance-like movements. You see those fidgeting movements or excess movements. And the brain is also able to keep some of it around so that by the time you take your next dose, you're still in that blue area. You still feel well without symptoms of slowness, rigidity, stiffness. As the disease progresses, that buffering capacity of the brain decreases. And importantly, the range where you feel well might decrease as well. So with each dose of levodopa, you may have a small period of time where you have excess movements as a result of the medication. And then before the next dose, you see here a trough period where you have time where you feel off with stiffness, slowness before the next dose of medication is due. And these two things, these two symptoms are the most important symptoms we think about in patients who are considering deep brain stimulation. The dyskinesias or excess movements, which occur as a result of medication, and specifically too much medication, and these off periods where the medication concentration has gone too low and you return to feeling a state of stiffness or slowness or trouble with gait, for example, in some cases. And then as the disease continues to progress, there may be times where individual doses of medication don't work. We call those dose failures. And the dyskinesias, those excess movements, become so severe that they cause pain, or they may impair your function, your ability to walk or be with people or do the things in your life that you want to do. And these middle periods where you have moderate Parkinson's disease, you have symptoms that are controlled by medications, but you have off times, or you have dyskinesias, or both, Those are the periods of time where we think most about deep brain stimulation being effective. And I'll tell you how that can happen. In addition to deep brain stimulation, I really want to stress that there's other therapies that are effective in addition to medication, and exercise is one that I'm sure all of your movement disorder specialists have reinforced, in addition to physical therapy and rehabilitation therapy, which is all the way over to the right. These are therapies that can really improve symptoms which medications sometimes can't touch, like difficulty walking, difficulty with balance, freezing. But in addition to medications like levodopa and then add-on therapies to extend the efficacy of levodopa, we also have surgical therapies. And there's two sort of over the course of many decades which have been effective or found to be effective for Parkinson's disease. One is called an ablative surgery, where heat is used to burn a small area of the brain. And that reduces abnormal involuntary movements like tremor. And it can sometimes improve stiffness and slowness. But much more recently, we've also developed deep brain stimulation, which is appealing in many ways because it can be, unlike a lesion or an area of the brain that has died because of the application of heat, deep brain stimulation causes changes that are reversible. You can apply an electrical stimulation, and if it's ineffective or causing side effects, you can remove it. So it's a very appealing procedural therapy in the sense that it's adaptable and it changes as you change and the disease changes. So what is deep brain stimulation? I'll explain it. I'll get into the meat of things a little bit better now, where it came from, what the history is, and how it works. It's a therapy which is based in those lesional therapies. So in the 30s and 40s and 50s, neurosurgeons found that by destroying small areas of the brain very selectively, using advanced neurosurgical techniques to target small areas, they could reduce tremor, or in some cases, they could improve slowness and stiffness. And that really started the field of functional neurosurgery in application of, to movement disorders like tremor and Parkinson's disease. It wasn't until the 80s when a team, including a doctor named Benabid, performed the first procedures where they applied high frequency, so lots of different individual pulses per second of electricity to areas of the brain. And they found that even by doing that, without causing a lesion, without causing that area of the brain to die, they could release some of the symptoms of Parkinson's disease, like reduce, like tremor and stiffness and slowness. And over the 90s and in 2000s, that therapy became tailored and very established and FDA approved for the treatment of Parkinson's disease. So for about the last 30 years, 25, 30 years, we've been using it actively in practice. And a number of trials that have been done have shown without question that it is a very effective treatment for symptoms of Parkinson's disease and can improve people's quality of life. But really, 30 years of active clinical usage on a background history of 80 years of advanced neurosurgical techniques. There are three components to a deep brain stimulation system. There is the implantable pulse generator. Think of this as the battery. It looks like a pacemaker in the chest, and it's placed under the skin just like a pacemaker. It's connected to wires that run up the neck, which themselves connect to two electrodes, which are placed by a surgeon through the skull into the brain very precisely and apply the electricity to the brain. So those are the three components of a deep brain stimulation system. DBS works by, like I said, or like I hinted at earlier in the talk, sending electrical pulses to an area of the brain via the electrode, which is also called the lead. And that lead applies the pulses at a very specific point in a targeted fashion to areas of the brain, which can, in this case, it's phrased stabilize brain signals. Well, we don't really know exactly how it works, but it does interfere with the processes that are causing slowness, stiffness, and tremor in the brain, such that when you have the stimulation on, those symptoms improve. And when you turn the stimulation off, they can return. So what are the benefits and risks of deep brain stimulation? The first I'd actually like to cover is the second on this list. It's increased mobility and decreased dyskinesia. So the most important concept in thinking about the benefit of deep brain stimulation is that patients have more good time, more off time, or more on time without symptoms of stiffness or slowness, while at the same time having less dyskinesia. So we often run into this wall, right? When we're treating with medications, we can't push the dose of medications any higher because people begin to experience dyskinesias which are bothering them. And at higher amounts of medication, those dyskinesias may worsen. So DBS allows us to extend the efficacy of those doses of medications, make them work better, while at the same time decreasing or suppressing those extra movements that occur as a result of the brain's response to the medication. The other important benefit is in tremor reduction. And this happens in a different way physiologically. It's a different mechanism, but tremor is reduced in some cases even more than with medications alone. So if you have tremor that is interfering with your life and impairing your ability to do things in your everyday life, and medications aren't improving that tremor sufficiently, deep brain stimulation can reduce the tremor more than the medications. In some cases, deep brain stimulation can allow us to reduce the doses of medications. And when I say this, it sounds appealing to many people because being on medications every day, multiple times a day, is inconvenient. And also some people very reasonably don't like the idea of taking medications very often. They would like to be somebody that takes less. I try to prioritize this benefit of deep brain stimulation for people that really can't take medications, and they can't take it because it causes a nausea that doesn't allow them to eat, or it causes dizziness that doesn't allow them to stand in such a way that they're really intolerant of medications. So for those people who can't tolerate medications which would otherwise be very effective for them, deep brain stimulation is a wonderful therapy that can be strongly considered. And sometimes it can have an ancillary benefit for other people of just reducing the doses of medications, but I try not to make that the primary focus. And then lastly, and very importantly, it improves measures of quality of life. So through all of these reductions in medication, tremor reduction, reductions in stiffness, slowness, and dyskinesia, people feel better, they're able to do more in their life, they have fewer symptoms of disease. But at the same time, deep brain stimulation is not a cure for Parkinson's disease. As much as we would love it to be, and as much as we'd like to see data and suggestion that it changes the course of disease, we don't see that. And it's important for you all to understand that while deep brain stimulation can be a very effective procedure in reducing your symptoms, it doesn't change the underlying course of the disease of Parkinson's disease. So what benefits might any one of you expect specifically? Well, the answer is this is unique to you. Parkinson's disease is different in every person, and the benefits of deep brain stimulation are different in every person. So if you speak to your physician, your neurologist, your movement disorder specialist about deep brain stimulation, they can and should discuss with you what benefits you may or may not expect. But there are, at the same time, a few rules of thumb, and I'll just go over 3 of them here. I sort of touched on them already, but just to reiterate them. Symptoms which improve with medications, especially those which tend to fluctuate with your doses of medications throughout the day, are those same symptoms that are most likely to respond to deep brain stimulation, meaning as you take your medications throughout the day, the control of those symptoms will be more even. You'll feel well all day instead of only part of the day, or most of the day instead of only part of the day. At the same time, the best that the deep brain stimulation can do is the exact same as your medication. So that best on time that you have, whether it's 8 hours a day or 1 hour a day, that best on time is the very best that the deep brain stimulation can achieve for you, but with more time for more on time per day and with less dyskinesia. And then the third rule of thumb, symptoms which persist during your on times, your best on times, are unlikely, unfortunately, to respond to deep brain stimulation. So those include difficulties with gait. Now, sometimes people with bad freezing and difficulties maintaining a good gait and maintaining balance, sometimes those people have those problems despite the doses of medications, and they never really improve. And in those people, deep brain stimulation can't hope to improve those symptoms either. Other people have changes in gait and balance, which actually might improve with dopamine. Might improve with levodopa. And in those people, we might expect a little bit of improvement with deep brain stimulation. So it really is individual, but the concept is, which important to understand, the symptoms which persist, continue when you're feeling your best on time with medications are unlikely to improve with deep brain stimulation. And the final exception to that is tremor. And I've touched on this, but tremor is unique in that even if it doesn't respond to medications, it can respond, and often does respond, very well to deep brain stimulation. We can achieve on average about a 70 to 80% reduction in tremor, and in some cases with good stimulation and good surgery, near complete resolution or suppression of tremor for a long period of time. At the same time, just like I wanted to stress that DBS is not a cure, there are risks and side effects which you need to be aware of. These are based on studies over the last 15 years, where during the surgery, we see about 2 to 3% of patients have a small amount of bleeding, and in a total of 1 out of every 100 or 1 out of every 50 people, that bleeding causes symptoms, which may be permanent. And then there's also a risk of infection, which is about 2 to 5% over many years. So around 1 in 50 to 1 in 20 people. And then risks of poor lead positioning, which really do depend on the center in the surgery, and fracture or malfunction of the system itself, or malfunction of the battery. All of those tend to be fixed percentages. There's another category of side effects, which are side effects of the electrical stimulation itself. And this is what I deal with. And fortunately, I can be proud to say that many of these side effects are temporary. Not only will they resolve completely if we turn off the stimulation, but by changing the kind of programming or the type of stimulation, we can reduce or eliminate many of these side effects, but all of them are possible. So it's important to understand both the risks and benefits in any procedure you're thinking of undergoing, and certainly deep brain stimulation. So are you a candidate? We've touched on these concepts, but I just want to reiterate a few things. There is something called the window of opportunity for deep brain stimulation, but this is a concept which just basically means you have symptoms which are responsive to medications, but which fluctuate throughout the day. And you have dyskinesias or other symptoms which prevent you from increasing the medications further. So I like to really think of it, that there's a window analogy. There's also this wall analogy, where we treat with medications as far as we can until we reach side effects. And if we've hit that wall where you have side effects of medications, but your symptoms are uncontrolled, if they persist for many hours throughout the day, if you have bad off time, this is a good time to think about deep brain stimulation. There's a number of medications which can also help with this problem. So being with a movement disorder specialist who is well-versed in the options available to patients with Parkinson's disease is wise, and will help you understand when really is the best time to think about a brain surgery rather than adjustments in medications. And then the details are listed underneath that diagram. So you have to have been diagnosed with Parkinson's disease typically more than 5 years before, because some diseases can look like Parkinson's disease, and we usually use that cutoff to be 100% certain that it's Parkinson's disease. Your symptoms need to be responsive to medications. But again, there needs to be some amount of off time throughout the day. And then side effects, which is typically dyskinesia or excess movement on medications. Or in some cases, you might have a tremor which interferes with your life and does not respond sufficiently to medications. The kinds of people which we think about not benefiting as much from deep brain stimulation, their quality of life would not be improved by the brain surgery, are those people who suffer from cognitive impairment or dementia from any cause, but sometimes from advanced Parkinson's disease. Or of course, if they have medical conditions where they can't undergo surgery. Or importantly, and this fits into the entire concept of that symptom responsiveness to medications, if you have symptoms which interfere with your quality of life and never get better with medications, if those symptoms are the main cause of the impairment of your quality of life, it may not be appropriate to think about deep brain stimulation, because it wouldn't be likely that those symptoms would improve if they don't respond to medications. So many of the same concepts, just sort of reorganized and reshuffled, presented in a different way. And again, I just wanted to show you this diagram again to reiterate that it's those people with moderate to early severe disease, those classifications are loose and not formal that benefit very much from deep brain stimulation by smoothing out these curves, by keeping you in that blue area with the same amount of medication. So what is actually involved in undergoing deep brain stimulation? I'll try to move quickly through this. One is to explore your options. That's what you're doing today. Speak to as many people as you can and look into many resources about understanding what this brain surgery entails and what it would mean for you. Talk to your movement disorder specialist or your neurologist about undergoing a DBS evaluation if they think it's appropriate, and find a center that you trust and that your movement disorders neurologist trusts to refer you to. Then undergo, if it's appropriate, the implantation of the device and the electrodes and then the battery, and undergo programming with me or an equivalent specialist in deep brain stimulation and movement disorders for a period of months or years before returning to your neurologist or continuing with that person. I'll go over each of these in details. There are two targets. I don't want to dwell on this. There's the globus pallidus and the subthalamic nucleus. This slice of the brain is kind of like a slice of bread, and you can see the line here around the scalp. That's the plane where we're looking at the brain. So these are structures that are deep towards the center of the brain. That's why it's called deep brain stimulation. And the other important concept is that they're very small. And we don't want to stimulate the entire structure. We want to stimulate a small area of that structure. And this is another diagram. You can see the structures are the same, but here we've also labeled some of the electric cables which connect the different areas of the brain together, those white matter tracks, those fiber bundles. And you can see what high value real estate territory this is. Not only are these small structures, but they're surrounded by communication lines from other structures. And so it's very important that not only do we place the device extremely precisely with a skilled surgeon, but that you have advanced programming techniques and a movement disorder specialist who knows what side effects to look out for and how to change the stimulation to reduce those or eliminate those side effects. One of the strategies which has been used in the past few years is something called directional stimulation. And you can see in this left-hand diagram, typically when the electricity is applied to an area of the electrode, it radiates out in a spherical direction, in all directions. What we can do with more recent advanced devices is send the electricity out from only one side of that electrode so that it stimulates not in a spherical area, but in an area that sort of looks like a little balloon, a little bubble to one side. And the reason that's important is because areas that cause efficacy and areas that cause side effects, like I said earlier, are very close together, very high value real estate territory. And so this is a cartoon from Boston Scientific, which I think demonstrates it well. The blue area is what you want to stimulate with the electricity, and the yellow area is what you don't. So you can imagine if you're just looking around stimulating in all directions, you might be able to stimulate areas of the blue while still catching the yellow. But by reducing and stimulating in one specific direction and using multiple contacts at that lead, all advanced techniques of stimulation and programming, we can stimulate a large area of the blue, the effective territory, and get good symptom control without stimulating any of those surrounding areas of side effects. So that is it's a tool that is at our disposal. Whether it is very beneficial to patients in the long term, we have still yet to understand. So which target is right for me? You know, we're getting on and I want to leave lots of time for questions. So I will just say that there are different benefits to the subthalamic nucleus and the globus pallidus. Both provide excellent control of on-off periods. The subthalamic nucleus may be a bit better for tremor. The globus pallidus may be a bit better for suppressing excess movements. But the differences are small and they're subtle. The subthalamic nucleus typically allows you to decrease medications. The globus pallidus does not. It works with your medications. But what specific area is best for you is always a nuanced, complex, individual decision. It's guided by your neurologist's advice and, most importantly, your goals and priorities, or of equal importance. There are 3 device manufacturers in this country, Abbott Labs, Boston Scientific, and Medtronic. And there are advantages and disadvantages to each of these devices as well. The Abbott device, for example, allows us to program patients from the comfort of their home if they can't come into clinic to do all of the programming remotely. But there is no rechargeable battery offered by Abbott. The Boston Scientific device has perhaps the most advanced programming options available, but it's complicated for neurologists to use. And so if your movement disorders neurologist has never used the device, it may not be the right choice for you. The Medtronic device is the longest. It's the old hat in the group, the one that most neurologists are most comfortable using. And it can also sometimes record brain signals record information from the brain in addition to stimulating. And that may become useful in the next 5 years. But at this point, it does not have the ability to offer directional stimulation. And the battery usage and performance is somewhat variable, although that's anecdotal and there's no hard data to suggest that. So I don't want to say that I favor one device over another. I think they all have their advantages and disadvantages. And like the Target, there's no best device. So this should be guided by, again, your goals, priorities, and your neurologist's advice, both the DBS team and your home neurologist or your movement disorder specialist. There's also the option of going rechargeable or not. Rechargeable batteries, you need to sit with 15 or 20 minutes a day with a device on your chest, or an hour or two a week in order to keep it charged. And that will allow it to last 15 years without needing to be replaced. A non-rechargeable battery is a set it and forget it. You can not think about having to maintain your device, but the downside is that it lasts only 2 to 5 years, so a much shorter lifespan. This again is an individual decision. So the first step, or the next step in this DBS journey after considering your options, is the initial evaluation. And this is when you go and visit with a DBS team like mine at USC, which is a multidisciplinary team comprised of a neurologist, a neurosurgeon, sometimes a nurse, a social worker. You discuss the options, you discuss your symptoms, and most importantly, you perform an on-off evaluation where you come into the clinic off of medications and see how your symptoms change an hour or two after you take your medications. That's important for us and you to understand what symptoms might respond to the stimulation. And then if it's decided that you'd like to undergo the surgery and we agree that you'd be a great candidate, then you would undergo a full neuropsychological evaluation with a neuropsychologist, usually offered by the same center, and then brain imaging, which is very specific and allows surgical planning. The surgery itself starts with the imaging and planning, like I just said, and then on the same day, you'll implant the lead. That is usually done in an overnight surgery. So you come in the morning, you have the brain surgery and you stay overnight. During the surgery, we make sure that the lead is in the exact right place. You know how high real estate that territory is. I've said it 4 times. We can do that one of 2 ways. One is with you awake and then doing physical examination testing, which is it's a tried and true method, which is very precise and is also guided by electrical recording from the brain. The other method is to use MRI guidance. This allows you to be asleep and seems, based on available evidence, to be equivalent. So the decision of which method to use is also somewhat in your control and to your preference. So I suggest choosing a center which might offer both. And then finally, the next step is securing the lead in place. On a separate day, sometimes this occurs on the same day, but usually on a separate day, you come back for a second surgery where the wire is connected from the electrode in the brain to the chest, and then the battery pack is implanted, and then you're closed. That's usually, the incision is closed rather. That usually is a day surgery. So you come in the morning and you're done by the afternoon and you can go home. And finally, 3 to 5 weeks later, you'll come into my clinic as a neurologist. We'll turn the device on. We'll run a full mapping of every contact on that electrode to figure out where we should apply the electricity in the best fashion. And that initial process takes about an hour or 2. And then every 3 to 4 weeks for the next few months, you'll come back and have that programming further optimized. We usually take about 30 minutes. In those sessions, you could be on medication. You don't need to be off medication. And if we get it right, which we almost always do in the first few months, then we can wait 3 to 4 months for you to come back, and we'll see you every 3 to 4 months for programming after that point. As the disease changes and your symptoms change, we can readjust the programming to treat those emergent symptoms. And we expect improvement over the gradual improvement over the first few months and sometimes over the first year. So I'd be remiss if I didn't just very quickly introduce you to the team at USC, and I'll do this very briefly, but Nazrin Esnashari is our nurse practitioner with 20 years of experience. Jennifer Huey, the lead neurologist, Darren Lee, Brian Lee, Mark Leiker, our neurosurgery team, and Andrew Petkis, our neuropsychologist, our multidisciplinary team. So at that point, I'm sorry I ran a little longer than I wanted to, but at this point, we'll have 20 or 30 minutes for questions, and whatever they are, I'm happy to take them.
Yes, thank you so much, Dr. Mason. We have time to take a few questions, and I see that we have several in our in the chat box. So we'll get right to it. So the first one is, what are the benefits of ablative surgery over DBS? Does it last longer, no follow-up surgery, better results?
I'll go over the advantages and disadvantages, and I'll do it briefly. In modern practice, we do not tend to use ablative surgeries. We almost always use deep brain stimulation. And the reason is because ablative surgeries have side effects which cannot be adjusted. Those side effects tend to be permanent if they occur. And the efficacy of ablative surgeries can also wane over time. And we can't adjust the lesion, the ablation in the brain, the way that we can with deep brain stimulation. So DBS has overall better outcomes over time and fewer side effects. The only situation where we would use an ablative or a lesional surgery these days is if you can't undergo a surgery at all. And the lesional surgery that we can use, it's not yet approved for Parkinson's disease, is focused ultrasound. So focused ultrasound therapy does not require that you go, that you have a surgery. But at the same time, the risks are slightly higher and the benefits may not persist as long. So we do tend to favor deep brain stimulation in those people that can have it, while lesional or ablative therapies are available as an option in people that can't undergo deep brain stimulation.
Okay, the next one from Jean Loring. What is your opinion about stem cell derived dopamine neuron replacement? Blue Rock has received an IND to start a clinical trial, and other companies will follow soon.
So this is very early days in the new generation of stem cell therapies. I can say that the early trials that were done about 25 years ago showed many more side effects than there were benefits. These new techniques may be more effective than those early trials, but they also come with as many risks from brain surgery as does DBS, and are certainly at this point very unproven. So with the caveat that this is not my area of expertise, and it's very exciting for patients and for physicians as a possible option in the future, I think we're at least about 5 years away from having a solid answer on whether any of these therapies are effective. So I think that's about as much as I can say at this point. I don't want to, offer too much subjective opinion. Try to base things on the data that I'm aware of.
Okay. We have another one here. I think you answered the first part of the question. I heard one should wait for at least 3 years from diagnosis of PD before considering DBS. But also, is there an age limit? I am 80 years old. That's from Michael Bauer.
Yeah, no, I appreciate the question. There's no definite age limit. It really depends on your functional status, whether you can undergo a surgery and whether your heart and the rest of your body is healthy enough to withstand a brain surgery, and what symptoms you have that are impairing your quality of life. So we don't have an absolute age cutoff, no.
Okay, great.
And I've had 80-year-olds undergo the surgery.
Oh, okay, wonderful. I think, again, I feel like we sort of covered this, but will results of DBS remain, or after time, can they change for better or worsen?
Well, we don't. So the real answer to your question is that we don't know how long DBS works, because we've only been using it for, in the longest patients, 20 years, about 20 to 5 years. But we see that the efficacy over that period of time persists. So in all of the data that we have, we can conclude that for perhaps decades, we can effectively treat the symptoms of disease better than medications alone. The disease changes over time, and so the effects of stimulation also change, and our type of stimulation in the programming may need to change over time as well. But it's a constant, give and take. It's a push pull as symptoms emerge. We try to treat them with adjustments in the deep brain stimulation. The simple answer to your question is that there's no falling off. There's no wearing off of the effects of deep brain stimulation. You should and can expect with a well-equipped center and a competent surgeon and neurologist that there would be persistent efficacy, over the rest of your life.
Okay, and this is sort of a little off topic. Has stimulation been tested on Huntington's disease?
It has. I'm not very familiar with those trials because it tends to not be very effective in the kinds of symptoms which are impairing people's quality of life. And it also doesn't change the course of disease. So it's been studied. Sometimes it can help the excess movements of Huntington's disease a little bit. But at the same time, the other symptoms of Huntington's, which are so disabling and tragically affect people's ability to live the life they want to live, those often don't respond. Things like the thinking changes and the behavior or emotional changes. Mm-hmm. So the easy answer is that it's been tested. It's not something that we use.
Okay, and do you think DBS will eventually be used on both sides instead of the current one side only?
DBS is used. Oh, I'm really happy that you asked that question. DBS is used on both sides.
Oh, it is.
So in some cases, we can just use it on one side. And if, for example, somebody has a tremor as a result of their Parkinson's disease, and it's only in one hand, or it really is only functionally impairing them through its effect on their dominant hand, sometimes we can do the DBS on one side. Mm-hmm. But for most patients with Parkinson's disease, I would say 9 out of 10, we do the DBS on both sides because that helps to treat the stiffness and slowness on both sides, suppress the dyskinesias.
Great. And this is the last typed one, and then we're going to take some verbal questions. So if you have a verbal question, you can please unmute yourself and you'll be able to ask it. I have one more. Will the effectiveness of DBS diminish over time like the medications? I guess this is the big question of the day.
Yeah, well, I think, and I'll reiterate that the DBS remains effective for the life of the device. And that is as long as somebody is willing to maintain it. So the best information we have now is that as long as you are following up with your neurologist and neurosurgeon, keeping the battery replaced or charged, and responding to changes in symptoms with changes in programming, that DBS has an effect over years to decades. The disease changes, and sometimes symptoms that were not impairing your quality of life when you had the device placed begin to impair your quality of life. And those symptoms may not be symptoms that would have responded to medications. So by the earlier logic in the talk, where I really stress that it's medication responsive symptoms that respond best to DBS, that might happen, and then the DBS can't improve those symptoms. So for example, if you're somebody who gets around really well right now, runs on track or walks around the neighborhood, but is very bothered by wearing off and dyskinesias, then the DBS is going to help you for many, many years. But down the line, 10, 15, 20 years from now, your gait, your walking, your balance may become affected by the Parkinson's disease. And in most people, that doesn't tend to respond to the medications in the same way that other symptoms do. And so the DBS wouldn't really be able to treat those as well either. So you see, it really is an interplay in the way that the disease changes over time and what symptoms are most effective in your quality of life. Again, the easy answer is that for those symptoms that it works for, it's going to work for it. It's going to work for those symptoms for decades, forever, to the best of our knowledge. But there sometimes can be a breakthrough tremor, for example, and there other times can be symptoms which the DBS could never have been expected to treat from the beginning that become more important for you and your quality of life.
Mm-hmm. Okay, so now we do have some time left. I'd like to give you an opportunity to unmute yourself and ask a question verbally if you have one. You can take a moment. Well, it looks like you were very thorough, obviously. Thank you, Dr. Mason. Any last minute burning desire questions? I think it was wonderful. Thank you so much. We really appreciate it. And good luck at USC. Oh, Michael, would you like to ask a question?
So are you suggesting that if you have less troublesome symptoms now, that it's better to get the DBS sooner rather than later, because it will maintain that level?
It's a difficult question to answer. The easy answer is that when you're into the disease, but you're having bothersome symptoms which don't respond to medications, that's the time to consider, or that do respond to medications but that fluctuate. That's the time to consider the deep brain stimulation. Your question was a little more complicated. You were saying, is it best to do the surgery when I'm, still feeling well and can still preserve some good quality of life?
Right, because you said the surgery maintains a certain level that you go into it with.
Yes, so it is important to say that the disease will keep changing, but that the surgery can help keep you more even throughout the course of the day.
Okay.
So it's not that it fixes the disease at one point.
No, I know that. Yeah.
Okay. Oh yeah. I'm struggling a little bit because I think the answer to your question is yes, it can help you maintain a good quality of life for longer.
Okay.
But it's not going to change symptoms from advancing or from new symptoms from occurring.
Right.
There's been studies now looking at whether we should do DBS in early disease, whether we should do surgery in patients who are still responding to medications.
Mm-hmm.
And though that has been a really difficult question to answer, and it kind of gets at your question a little bit.
Yeah.
So far, there are very few opportunities to study that question, and so it remains unanswered. But probably the answer is no. I mean, if somebody is responding to medications and doing well, they may respond to medications for the rest of their life.
Okay.
It's really in this territory where you're responding, but there's fluctuations, there's dyskinesias. You can't quite get the medicines right. That DBS can really help even things out. And at that point, you would maintain a good quality of life for longer.
Thank you.
Robert, did you have a question?
I have two. Are there times where the effectiveness will come and go and be, sort of like that, or is it all sort of like out of the gate, and does it start right away as soon as surgery is over, or does it develop as the brain changes?
It does. The evening out of the effect of medications occurs gradually. So I think the way to answer your question is, if you have big ups and downs, the first few months, those might become diminished, but you might still have some ups and downs throughout the day. But as we adjust the stimulation in your medications, then we can much more easily get you to a place where you're well treated throughout the day. You might still have some off time. There may still be subtle ups and downs, but it will be much improved relative to prior.
And real quick, are there insurances that don't cover this?
I'm so sorry, I can't answer that in much detail. Some insurances don't cover it as easily, but if it's appropriate, all insurances should cover it.
Michael, you had a question, Michael Bauer.
I've been resisting taking medication and don't know whether that's a good thing or not, because I understand it wears off eventually. This way I'm not starting yet, so I don't know if I'm buying time or if it's a smart thing to do. But your thoughts?
Well, it's a different question. I could give a whole lecture on that topic.
I know.
But the easy answer to your question is that, like I said in that slide, it really is that the disease changes your brain's response to the medicines rather than the medicine causing these side effects on their own. So, I tend to say to a question like this, if you have symptoms that are impairing your life, that we can treat those symptoms and then adjust medications over time. So it just depends how bothered you are by your symptoms. I would rather you have I'd rather you have a good couple years on the front end and then adjust the medications down the road than see you, suffer through these first couple years, without a definite benefit down the line. But you're not alone, and there's there's no easy answer to that question.
Not inhibiting me. I've got tremors, but it's not causing my. I still can play golf, and that's the most important thing right now.
Oh, there you go.
I could talk forever about that question, but Karina has had her hand up for a long time.
Yeah, Karina.
Let me unmute myself. I don't know if I missed this because I have a lot going on over here. Number one, is there an age requirement? Like, does anybody age out of being, because this is all for my dad, and he's 80 years old. Is he too old for the DBS surgery?
No, there's no specific age. There's no specific age cutoff. I mean, we tend to think twice when people are in their 80s. Certainly 2 or 3 times. But if we can be sure that their quality of life will improve and that they can withstand the surgery, then we'll go ahead.
And then the second question is, as I was taking notes with the whole PowerPoint, I mean, he has more down days and he's newly diagnosed. So for us, it seems like it progressed very quickly. So, the reason why I started researching DBS is I have someone that I know has a father who had the surgery. My dad's biggest problem is his balance. He falls constantly, right? He doesn't have tremors or anything like that. It's his speech and the balance. So from what I am understanding from the PowerPoint, though, if he has more off times, then it really wouldn't be like such a great thing for him.
Well, there's 3 parts to your question. One is that he's newly diagnosed. And that gives us pause because there are diseases that can look like Parkinson's disease that are not Parkinson's disease. Those tend not to respond to deep brain stimulation as well. That's point number 1. Point number 2 is that some symptoms of real Parkinson, a bona fide Parkinson's disease don't respond to medications. And that typically includes balance and gait. And if that is a major contributor to, your father's poor quality of life with these symptoms, then that is not something that the DBS can be expected to improve unless it clearly responds to the medications. And even then it's debatable, but the current evidence suggests that it does. And then the third part of your question is about off time. Yes, certainly if off time is a major contributor to, again, your father's poor quality of life, everything else held equal, then the DBS could help that off time. But it seems like there's a lot of other pieces which we would need to address first in thinking about whether DBS would be right for somebody like your father.
Thank you.
Well, Dr. Mason, thank you again. This was so informative. I want to thank you all for joining us today for our online education event brought to you by PCLA and Boston Scientific. It was really wonderful. Please join us next week for a webinar on the latest in Parkinson's research 2021 with movement disorder specialist Dr. Jeff Bronstein from UCLA. And this event is part of our Let's Talk Parkinson's series. Thank you and there are program sponsors as well. Today's program was brought to you by Boston Scientific, Advancing Science for Life, and by PCLA. Please, if you like this event and you found it helpful, please consider donating today at PCLA.org or reaching out to us at info@PCLA.org. You can reach our information and referral specialist, Sarah King, at 310-880-3143. Thank you so much. We continue to do our work to help people in the Parkinson's community have great quality in their lives.
Thanks,
Thank
Judy.
you again. Thank you so much.
Thanks for your attention. Thanks for having me.
Thanks, everybody.
Thanks, Dr. Mason.
Thank you, Dr. Mason. Thanks, everybody.
Thank you, Dr. Mason.
well.
Thanks all.